This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Because the reality is the individuals that are losing coverage on Medicaid and on the exchanges, they seldom have another path to healthcare coverage. That means then they're not shifting from one covered status to another. They're shifting from a covered status to uninsured, which has serious implications on how they're accessing care, as well as the financial outlook of the health system as well.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. Today, we are going to talk about the Sg2 insurance coverage forecast for 2026. I have Tori, Richie, who no one else could talk about the insurance coverage forecast without having Tori there, and her partner in crime, Karyl Kopaskie. Several others contribute to this product at the specific payer class level, myself included, so you'll be subject to hearing from me a little bit later as well. This was a big change in this year's forecast with many contributing factors. We're going to break it down and give you the biggest themes by payer class, and then we'll talk about how we're connecting what we've learned through this process to plug it into our IOC forecasts at a bigger level and think about the impacts on utilization and demand. This isn't the only place you can hear us talk about our insurance coverage forecast. There's also a webinar that came out today. If you want to see visuals, see our charts and graphs about how we expect these different payer classes to move, you can always do that at sg2.com. Tori and Karyl, thanks so much for joining. First up, Medicaid. How are we forecasting coverage in Medicaid is going to shift over the next 5 years?
To just be direct about things, we expect there to be substantial attrition to the Medicaid population. Throughout the course of 2025, we saw attrition to Medicaid enrollment. If you look at Medicaid enrollment reports from CMS, we see about 1.5 million fewer people enrolled in Medicaid in August, which is the most recent available report compared to January of 2025. Layer on top of that, the passage of the One Big Beautiful Bill in July of 2025, we expect that attrition to accelerate as provisions from that law go into effect over the next handful of years. So with the implementation of things like work requirements, increased scrutiny related to eligibility, we expect there to be robust attrition, particularly in Medicaid expansion states, almost exclusively to adults. We do expect there to be attrition in pediatric or child enrollment in Medicaid, but that population is much less affected than their adult cohorts. But certainly nobody comes out of this unscathed.
To echo you there, Tori, we do expect the bulk of this to be felt by those expansion targeted populations, but it is a good call out that those populations who are eligible will still face additional barriers when it comes to hoops to jump through, paperwork and frequency in redetermination processes. So important to have that clear eye look at all of your populations within Medicaid. We will see some attrition across the board, the bulk of that falling to the adult population in that expansion group.
When we think about coming out of the COVID-19 pandemic, with the expiration of the public health emergency, the redeterminations that took place, nearly 3/4 of individuals who lost Medicaid coverage during those redeterminations, it was for administrative reasons. It's because they weren't able to verify eligibility. Individuals had a hard time supplying documentation or verifying that they were eligible for Medicaid. And it's likely we'll see a very similar dynamic play out here, that the individuals who lose Medicaid coverage as OB3 is implemented, it's not necessarily because those individuals aren't meeting the work requirements. It's because it's challenging their barriers to submitting that documentation, having to go through redeterminations twice a year, every 6 months. That's a major administrative burden on enrollees, but also the state Medicaid programs who have to then process and file that paperwork as well.
Talked about timing. You mentioned we already saw some attrition during 2025, but this isn't like a linear forecast for the next 5 years of how things are going to change.
It is not linear. In order to nail the timing as it relates to implementation of OB3, we leveraged estimates from the Congressional Budget Office. They did some sizing in terms of when exactly is this impact expected to hit. We do expect there to be an impact in 2026 that will further accelerate in 2027 and 2028. That's when we'll feel the bulk of this impact, with then still some lingering attrition that carries through the duration of the forecast timeframe from 2028 then through 2031.
Thanks for that detail. Another area, our forecast driven largely by federal policy changes, is the exchange and ACA market, another place with attrition in the forecast.
Long story short, uninsured is expected to grow as a result of these drivers. The exchange population, there are some effects expected because of OB3 on the exchange population. There are changes to special enrollment periods. There are changes to who's eligible for subsidies, and that's going to drive some attrition. But also at the end of 2025, we saw the expiration of the enhanced premium tax credits that have been in place since the COVID-19 pandemic. That's what's going to drive the bulk of attrition in the marketplace exchanges. And that timing is going to be localized over the next year or so.
It's an important distinction to make. While we are expecting the attrition in Medicaid to be spread out more over that 5-year timeframe, we do anticipate the impacts of those enhanced premium tax credit expiration to be much more front-loaded. And so you'll see more of that impact in that specific cohort in the first year or two of the forecast, as opposed to the Medicaid impacts, which are a little bit more spread out. And also, when we're thinking about how and when patients are going to feel that sticker shock, we did already see that during the enrollment for 2026, without those tax credits in place, we did start to see effects of that sticker shock already. The estimates right now are about 8 million people have been preliminarily enrolled. And if we compare that to a total enrollment of almost over 24 million in 2025, that's already a pretty big gap. I know those numbers are not final yet, so we'll have to continue to watch that. But we did see some substantial sticker shock for enrollees this year. And then we are also going to feel that again in April when tax time rolls around and when those tax credits are not there. Thinking about an initial impact from some sticker shock due to the price increases we saw going into 2026, compounded by what's potentially larger price increases again for year 2027 as the risk pool becomes more complex, but then also the expiration of those tax credits, making it more visible to enrollees how big of a cost that they're actually going to be carrying. This is one we are watching closely. We think that there's certainly a lot of conversation still in Congress. There's still conversation about what action states might take to help mitigate some of these effects for their patients or for their enrollees. There's a lot that we are watching here, but based on the projections and the data that we have right now, we are expecting that pretty strong attrition from the insurance market exchanges in the first 2 years.
Let's move to an easier one because both of those, Karyl and Tori, summarized easily, but it was weeks of debate to figure out how we were going to localize those. Let's talk about commercial.
Before we jump to commercial, I do want to just call out quickly that it's really important that listeners and those of us on the line here, that we stay on top of the action that states are taking. Becker's has a great listicle going of movement that's happening at the state level, both from insurance marketplace as well as then Medicaid, what steps states are taking to help blunt the impact of some of this expected attrition. There's also a role for health systems in this work as well, because the reality is the individuals that are losing coverage on Medicaid and on the exchanges seldom have another path to healthcare coverage. That means then they're not shifting from one covered status to another. They're shifting from a covered status to uninsured, which has very serious implications on how they're accessing care, as well as the financial outlook of the health system as well. But just want to drive home the importance of keeping a pulse on how it is that you can drive mitigation strategies to help protect yourself in this environment. Commercial was much more straightforward to forecast this year. We're pretty much holding steady. We're not predicting attrition to commercial for any reason other than people are aging into Medicare. That is the only reason why you start to see slight attrition to that commercial patient population. It's an effect of the aging population. Something that we did heavily scrutinize was the breakdown of how we're distributing the population across the different commercial plan types. This year, we are leveraging different consumer survey data. We're leveraging Sg2's consumer survey data to inform that distribution at a state level, how commercial enrollees are distributed across plans. That's yielding a much higher proportion of the population leaning toward a high deductible health plan. When we look at the forecast projection and the long range, we expect uptake of those high deductible health plans to continue. We have not come across anything that suggests that costs are going to be better contained or that employers are going to be able to prevent the need to pass some of that cost along to their employees. And so we imagine that that's going to continue to fuel adoption of those high deductible health plans.
This is an important consideration as we're thinking about, while that commercial enrollment as a whole is not necessarily changing a ton outside of the insurance marketplace. We're actually projecting now by 2031 that over half of those commercial plans will be a high deductible health plan. And that does have a significant impact on how patients are able to access and use the insurance coverage that they do have. And so as we think about the critical point we want to get to is the so what? What do we do about this as a health system? That's one of those pieces we're going to want to keep in mind is what is that high deductible health plan penetration in your market? And how is that going to help patients bridge that gap? As we know that the average out-of-pocket cost for a patient with high deductible health plan is significant, especially in that first half of the year.
And Karyl, to that point, it's worth noting that within the description of high deductible health plan, there is quite a difference between somebody with a deductible of $1,700, the baseline, versus $8,000. Something that we had a lot of debate on and conversation about was, even though technically people might be covered, they might have some type of insurance, we expect to see a rise in the underinsured population. And so that's going to really inform the decision-making process of how, when, where patients are accessing care because of that extreme price sensitivity that's attached with maybe technically having a plan, but it operates more like a catastrophic plan instead of a fully robust or comprehensive one.
And we think about that in the context of those stats saying that a $400 health expense can be an unsurmountable burden for many households in America. When you're talking about even a deductible of $1,700 could be really difficult for a lot of patients.
And every year we debate, are we going to forecast a growth in ICHRA, defined contribution instead of defined benefit? And this year we reached the same conclusion we have in years past. It's still low single digits in terms of the impact so far. We haven't seen that grow. I don't think it's going to grow substantially in the next 5 years.
ICHRA is such an interesting concept, and it's something that we've tracked for the 10 years that I've worked on this forecast. It's always sort of in the background, and in some instances, it seems to be gaining momentum. It's just such a small slice of the pie that it hasn't substantially driven our decision-making process in terms of what to do with that cohort. Trevor, I do think it's worth noting there was a lot of debate on Medicare, and you and the team have a different and much more nuanced approach to forecasting this population.
That's because our colleague Ryota leaned in and helped a lot with the modeling here. But the big trend we knew coming into this year was the rapid growth that we saw from 2021 to 2024 of people moving into and selecting Medicare Advantage, especially when they age in, but also switching from traditional fee-for-service into Medicare Advantage after 65 had slowed from 24 to 25. We saw that payers were saying that was because they couldn't manage utilization and they weren't any longer making margin on this population. Their MLRs were too high. MLRs peaked Q4 of 2024. So we knew there was going to be some correction from the payer perspective in terms of products they offered and benefits they offered. Then we got to see the proportion of enrollees that were in plans that actually terminated where the payer said, we can't offer this plan anymore. And it was over 6% of all enrollees in Medicare Advantage this fall got a letter saying your plan doesn't exist anymore. You can pick another MA plan or move back to fee-for-service Medicare. That's the highest number in over 10 years. Right after the financial crisis in 2009-10, the Medicare Advantage terminations hit about that same level. There was a research study that looked at every year, the normal most years is like 1% of people are terminated. There was a study that looked back, how many of those people continue to pick Medicare Advantage versus pick fee-for-service? It's only about 10% end up leaving Medicare Advantage. Most pick a different product. That contributed significantly to our forecast because the plans are organized at a state level, but the products are offered at a county level. So we saw huge variation across the country in terms of the proportion of enrollees in a given county who were getting terminated. There really wasn't a pattern across the country. You could say, oh, it's very clearly in urban areas with big growth. There was no pattern. It was largely driven, we expect, by just plan performance. If we couldn't manage utilization for the enrollees who enrolled in this plan in this given geography, we just have to terminate, knowing that in some cases that payer still offers plans in that market and it may just be the enrollees moving into another plan. That's a bigger change than we've seen in the last several years. What that really means is we're forecasting that Medicare Advantage, it's not going to turn around and start to decline, but it's going to flatten for a couple of years. And then we expect probably, this is the pattern we saw the last time terminations were this high. It stabilized in a couple of years, and we're forecasting growth to pick back up starting in 2028.
It's exciting to also understand there's a lot more sensitivity that you and Ryota modeled into the county level projections as well. Sure, nationally, Medicare Advantage adoption isn't declining, but in select markets, it is. And you all have captured that dynamic, which is really exciting. And it allows us to hone the accuracy and sensitivity of the product as a result.
And at the county level, because we were able to get precise, because we had pretty precise data about enrollment, what we know is some of these counties are going to be way off because there's not perfect historical data about how enrollees have chosen to stay in MA or not, because we're in a totally different set of circumstances. And we expect still most enrollees are going to make that decision based on economics. And there may or may not be products available in those markets that have low or $0 premiums because payers have said that's where they're going to focus on trimming benefits and increasing premiums. Many big changes across the forecast. Some markets with 40+% of enrollees realizing they're going to have to pick a new product. Big changes at the county level, cumulative, flat nationally for Medicare Advantage. That was a lot of nuts and bolts details. You can imagine how many fun discussions we get to have debating the impact of this stuff. Well, fun for us. So talk about how members can use this data. What are the strategic impacts? How are you expecting members are going to adapt this to forecasting demand and utilization?
Certainly, we have national targets in mind when we're building these projections, but we do our best to really capture that local and market level nuance. What's playing out in an expansion state where insurance marketplace adoption was rather robust and there was quite a bit of bronze plan enrollment. The dynamics that are playing out there in terms of increasing uninsured population are quite different than if you're in a non-expansion state and you have a high proportion of individuals on the exchanges that are in platinum plans. Taking the time to parse out those details and hone the outputs allows us to drive a level of sensitivity that enables health systems to understand how are my communities shifting across those different financial groups. What is most likely to play out within my market? And then what does that mean in terms of sizing, utilization, and the financial impacts as a result as I start thinking about what my payer mix is going to look like when folks need or require medical care.
And as we think about what are those to-dos, especially thinking about that hospital administrator, that C-suite group who may be leveraging this data, there are two words that we've been saying is scenario modeling. That's really going to be the name of the game here. Because as we even alluded to it before, there's still a lot of moving parts when it comes to how states are going to respond, how local plan makeup is going to change over the next couple of years, and how patients are going to respond and how they may change their utilization. So the insurance coverage estimates are one tool and one input that you can use to help you get that strong core for what's going to be that likely outcome in your market. And then you can use that tool. Plus, if you have the impact of change forecasts, we've also built in effects of the changes in utilization based on these coverage changes into your local market forecast as well. So that's another utilization change on top of coverage estimate changes year over year. How is that going to change what our utilization looks like and how that way that change some of the strategic goals we set or tactics we try? But it also allows for some of that scenario planning around state level and local response. So what we know is that we haven't seen fully yet what the states are going to do in response to help support their different communities who may be becoming uninsured as a result of some of these policy changes. And so thinking through what might be some of those actions that we can take, or even allowing this type of modeling to be a starting point for conversations between health systems and local officials for what might be some of those appropriate responses we can take to help mitigate some of the effects of these policy changes. That is one critical thing that health systems can be doing and leveraging these tools to do so. It's also a really important opportunity. We've always said that collaborating across the different silos within a health system is critical for effective strategy. This is a situation where now more than ever, we really need to have those strategy teams, those finance teams, and those operation teams working together on building those scenario models so that we can ensure we've got a strong financial, operational, and strategic outlook for the enterprise that we can then use to help communicate and educate with either partners in the community or those local government officials to help drive policy interventions that might help to mitigate effects for people in our community.
The reality is if we take into consideration all of the different dynamics and levers that we've discussed, we are going to see a rise in uncompensated and charity care over the coming years within the healthcare system. And so what that means is making sure that strategy, operations, and finance are aligned. That means thinking through what processes do you need to stand up to verify insurance before individuals interface with your system? Are there resources that you can connect patients with to help them retain or perhaps enroll in coverage? How do you proactively flag individuals who might be eligible for Medicaid, but either aren't aware of that or they've had issues submitting documentation? Also, from a resource planning perspective, thinking about the fluctuations that are likely to occur in utilization patterns. Where do you expect to see declines perhaps in low acuity disease management care? Think behavioral health, chronic disease management, primary care, and by the deferral of those services, what emergency department and inpatient services do you expect to see increases in because people have now experienced an exacerbation of their patient condition? And what does that mean in terms of margin protection? How, from a financial side then, how do you protect your margin? How do you ensure then that you're operating efficiently and reducing waste wherever possible, knowing that some of these other dynamics are playing out across your system?
Well said, and a good note to end on. Maybe sadly, this is our last discussion about the ICF for 2026. We have a lot of fun and debate where we think the stuff could go. Tori and Karyl, thanks so much for joining and sharing your perspective. Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.